Hello, my name is Dean Contover, and this is Current Buzz. Today we have Graham Moore. He's an Educational Outreach Director for the Initiative Petition Question number 4. You all received this book, and I hope you read it. We're going to talk about question number 4. Question number 4 is limited legalization and regulations of certain natural, not synthetic, psychedelic substances. And that's why we have Graham here, because he's in a group that supports this initiative petition. And thank you for coming, Graham, in regards to talking about these substances. What I know of them is that there's psilocybin, which is from a mushroom,
Yep.
and there's mescaline from plants. Is it cactus or something?
It's cactus. It's multiple species of cactus.
And the indigenous people have been using this substance for thousands of years, we believe.
Yeah, at least hundreds, probably thousands. Yes,
and it's natural and it's organic, and now it's on the initiative petition in November, and that's why you're here. Oregon and Utah, it's legal. In Colorado, it's legal. Is that correct?
Well, so it depends on the substance.
Okay.
So Oregon's program only pertains to psilocybin and psilocin. So two of the substances in our measure are essentially the same thing. So psilocybin, when people ingest it, converts to psilocin.
Okay.
And so Oregon's program only deals with psilocybin mushrooms.
Okay.
Colorado's program is basically the same as ours. So it does encompass both psilocybin and mescaline, the chemical in the cacti, as well as the other substances in our measure, dimethyltryptamine, better known as DMT, and ibogaine, which is an African psychedelic.
Okay.
Utah's program is a pilot program administering psilocybin and MDMA to patients in hospital settings exclusively. And our bill does not contain MDMA. So Utah, Oregon, and Colorado all allow access to psilocybin and psilocin, essentially. Oregon and Utah only psilocybin and psilocin.
I don't want to go into the weeds.
Oh, sorry. Yes.
Run this, but in question number 4, and you should read it in detail. I read it last night because I knew Graham was coming. And I asked Graham and his people to come on and explain why we need this for Massachusetts. It's basically for PTSD, depression, anxiety, people who have that. So,
and substance abuse, and people suffering from addiction to alcohol, tobacco, opioids. That's where the most evidence is for these substances.
Okay, all right. So why should we vote yes on this question?
So first of all, Dean, I want to thank you for having me on this program.
You're welcome.
Again, I'm the Educational Outreach Director for Yes on 4, the organization advancing this measure. It's an honor to be here on Chelmsford TV, so thank you. Why should people vote for this measure is because the conditions that these substances show value in treating are life-threatening and debilitating. Those conditions include end-of-life, anxiety and distress for people dealing with life-threatening cancer or other diagnoses or a terminal diagnosis. Those conditions include PTSD, which is especially a life-threatening illness for people with very severe cases, particularly our veteran population. Over 6,000 veterans die by suicide every year in this country. It's been an epidemic for decades. And also for substance addiction, particularly opioid addiction, which has been an epidemic in our state and across the country, and again kills many people every year. So we can't afford to wait to provide more treatment solutions, and all of these treatments, all of the things that we're proposing to make available in a regulated setting in Massachusetts are already legal abroad. So people who are wealthy or get help from nonprofits, they can already go and access these treatments overseas. Two of the substances are actually prescription medications already. So psilocybin is a prescription medication in Australia for treatment-resistant depression. Ibogaine is a prescription medication in a few countries, but specifically in New Zealand, it's been used off-label to treat opioid addiction since around around 2010, 2012. So these are already being used. They've already been found to be effective in real-world settings. People are already accessing them. either in the underground, which is risky, or they're going abroad if they can afford it, or they're so lucky to get that sponsored. We want to make it easier for people to access it here, safer for people to access it here by creating regulated therapeutic access in Massachusetts.
You mentioned veterans and everything. Do you know if the VA is doing any studies on this or using it for veterans at all?
Yes, so the VA is actively studying psilocybin for mental illness in the veteran population. However, our measure does not directly pertain to that because the VA is going to wait to bring this online until it's FDA approved. FDA approval for psilocybin, one of the substances in our measure, the most well-researched substance in our measure, is anticipated within around 3 years. However, even once it gets approved, we anticipate access being very, very limited, which is another reason why it's important for us to pass this measure. In Australia, for example, treatment with psilocybin, because it is a new treatment, costs around $25,000
Wow.
USD approximately. And even if you can afford to pay that, it's hard to get approval. So we want to make it more accessible here for cheaper through this program. And again, in a safe, regulated setting. People are already accessing it. We want to make it safe and regulated.
Okay. So do I have to get medical clearance to have psilocybin done? Do I have to see a physician? How is this set up? I did read the book, but I wasn't clear on who would pay for this and how it would be paid. Would it be out of pocket in regards to the person that's having this treatment? Or?
So those are two different questions.
Okay.
So let me answer the first one.
Okay.
As for whether you would need a referral from a healthcare professional, that's going to be determined by the 2-year rulemaking and implementation process that's specified in the bill. So people should understand that this isn't going to pass and right away we're going to have people going to clinics willy-nilly doing this stuff. There's a approximately 2-year rulemaking period that is led by experts appointed by the governor, attorney general, and treasurer. And by law, in this measure, that body of experts must have a mental health expert and a medical emergency services expert. So they're going to determine what's most appropriate in terms of approval. So it's not specified in law whether a referral from a healthcare professional will be required, but if the expert body determines that, that's what will happen.
I see.
So we'll see. As for the second question, in terms of reimbursement and payment, we do not anticipate insurance covering this right away. We don't think insurance will cover the substances themselves because they're not until they're FDA approved. However, it is possible that insurance might eventually cover the therapy that is administered in conjunction with the substances. So that may be a pathway. But initially, we anticipate people paying for this out of pocket.
Okay. The legislation or the initial petition states that you will have a natural psychedelic substance commission of 5 members. Can you explain that and pontificate on that a little more?
Yeah, so as I previously said, elected leaders are going to appoint this commission. That commission will be paid and they will set up the rules and regulations for this program in consultation with an unpaid advisory board over the course of 2 years.
And that's called the Natural Psychedelic Substance Advisory members, 20 members, right? A board.
I believe it's 15, but yes.
I read 20, I'm sorry.
No. Yeah. So I think it's 20 with the commission plus the 15.
Okay.
But I may be off.
Yeah.
But anyway,
Right.
it's an extensive body of experts who will help make these rules in consultation with the commission.
And so they will give advice to the Natural Psychedelic Substance Commission board of 5 people.
Exactly.
They would advise.
Exactly.
And the board of 20 will be non-paid.
The advisory board, the advisory members will be unpaid.
Paid.
Yes.
And the commission.
Will be paid. Those 5 members will be paid.
Okay.
Yes.
All right. Good. Anything in regards to the board that you want to talk about, what they will do or how they will set this up? Like you said, there's a 2-year window.
Yeah, there's a 2-year window. So a lot of it is sort of up to the discretion of the board themselves. However, one thing that is specified by law is that the first licenses for administering this have to start going out in 2026, I believe.
Okay.
So it's not an unlimited period for implementation. And then the other thing that's important to note is it's not all substances in this measure being made available right away. So actually the law specifies that only one of the substances is actually going to be made available within the first, after that 2-year period.
Right.
And then after that, based on how the program rolls out, and at the discretion of the regulatory body, more substances can be made available through this therapeutic pathway.
Okay. Who will be allowed to grow this in regards to mushrooms? And
So the focus of this bill is the regulated therapeutic portion.
right.
The American Medical Association recently came out and said that personal substance use should be treated as a public health rather than a criminal issue. So what this measure does by removing criminal penalties for limited personal use is allow law enforcement to focus on serious crime and not prosecute people for activity that the research says is typically benign. So people older than 21 would be able to grow within a limited space these substances in their homes were this to pass. However, anything they grew would have to be secured from access by people younger than 21. Furthermore, selling and buying this is going to remain illegal under this measure. So one thing that's very, very important for people to understand is that there's no retail component. This measure does not create an industry like cannabis.
Right.
So people cannot go into stores and purchase it and take it home
Oh, that's
under
too
this
bad.
measure.
I'm only kidding.
We're trying to be very measured in line
Right.
with the evidence. And people can't grow stuff in their home and sell it either. The goal here is to remove criminal penalties for limited personal use to let law enforcement focus on serious crime. People are already using these substances. People are already growing these substances. In Massachusetts alone, over 8 localities have already effectively decriminalized through local resolutions growing and possessing these substances. These communities include Salem, Cambridge, Somerville, Amherst, Northampton, East Hampton, and Provincetown. So already all across the state, people are effectively able to grow these things for personal use. It hasn't been a public health issue. We're just trying to help law enforcement not waste their time and not prosecute people for healing, but we are not encouraging people to use these things by themselves. We're creating a regulated pathway as a model for safe, responsible use.
So this would be up to town meetings to bring it into their community or allow it into their community. Is that my understanding of it?
In the measure itself, communities cannot explicitly say that this doesn't go into effect or that a healing center, a psychedelic therapy center cannot be in their town. However, they are able to set regulations through zoning about how that can operate.
I see,
Yeah.
I see. Okay. So it would be a zoning issue, basically. Is that my understanding of it?
Yes, and again, they could set rules in terms of the hours of operation, where it would be located, I believe. So, but I think what's really important for people to understand is we do not anticipate this being a large industry. So by default, only a tiny percentage of adults use these substances, under 5%, according to a recent survey study done.
Oh, wow.
So a very tiny percentage of people use these, and most people use these very infrequently. So in clinical or controlled environments, typically just 1 or 2 doses of these substances is sufficient to produce months, and in some cases even years, of clinically significant relief from mental health conditions and addictions. Mm-hmm. And even people using these outside of a controlled setting tend to do them very infrequently. Again, maybe once or twice in a lifetime. So this is never going to be a big money thing. On top of that, the law specifies that in terms of the regulated access, anybody seeking to use these substances has to have a minimum of 3 appointments.
Okay, explain the 3 appointments.
Yeah. So the first thing is even before they have one of those appointments, they have to be screened. So
that's understandable.
Yeah. So the law specifies that before people access this care, they have to be screened to make sure if they have a contraindication for using this, they don't access the care. If they get through the screening, then the law specifies they have to have 3 appointments. The first appointment is a preparation session, and in that session, they're informed by a licensed professional about how the experience is going to go, and they're able to set their intention and prepare for, again, this sort of intense therapeutic experience. After that, and in Oregon, where a program like this is already established, there's a waiting period of 24 hours. So after the preparation session, and probably after a waiting period, they then come in to be administered one of these therapeutic substances. When they're administered the substance, they take it under the supervision 100% of a licensed professional. So they're not alone, except when they go to the bathroom.
Right.
So they're watched the entire period, and afterwards they have to be driven home. They can't drive.
Yeah, right. That's on the
Now after that, the law specifies they have to come in for a third appointment, an integration session, to make sure they're safe and to help integrate the experience they had moving forward. So for example, if somebody had a drinking problem, they take the psilocybin, they feel a lot better, they now feel perhaps no longer the craving to drink anymore.
Wow, that's interesting.
However, to make sure that the benefits endure, they would then have that integration session so they could be counseled on how to avoid getting back into bad habits, picking up the bottle again, so that the opportunity, the window they have to stay sober is not wasted. So that integration session is really important for helping maximize the therapeutic benefit for people accessing these substances therapeutically. So because of this model, we don't anticipate a lot of use of this. In Oregon, typically, people don't access this more than twice in a year.
Oh, no kidding.
Yeah, so this is something people access infrequently. So we don't anticipate there being clinics or these places in every single town across the state. The demand probably just can't sustain that many businesses. So people shouldn't be expecting this to be like cannabis, where there's a psychedelic center on every corner or a billboard's up like I saw driving here to Chelmsford today. This is going to be a minor industry, and it's going to have a focus on therapeutic use. This isn't a recreational model. This isn't a retail model. Nobody's going to want to go through 3 appointments just to take a drug for fun. This is about people who really, really want to get better.
Okay. The question I have in regards to driving, in regards to the amounts and driving, do we have any record of people driving on psilocybin, or have people been arrested for driving allegedly on psilocybin?
So for psilocybin, the substances in this measure, impaired driving in the real world has never really been a concern.
Okay.
So there was one study about people driving under the influence of hallucinogens. However, that study had a lot of limitations in terms of how it can be applied to our measure. So in that study, the amount of substances they were looking at was considerably larger than the substances in this measure. On top of that, it didn't say what people were taking or the dosages, et cetera, and it was also a national study. But the reality is there hasn't been a single study that has tied access to these substances to an increase in traffic accidents. Mm-hmm. And in Colorado, which passed basically the same measure as we're proposing in Massachusetts, impaired driving-related fatalities decreased by hold on, let me check the number right here, by 23.8%
Okay.
after the measure passed. So there's no evidence that this is going to make Massachusetts roadways more dangerous, and that's really, really important. I'll just say right now, the evidence is overwhelmingly in favor of this, and I encourage anybody at home who's watching this to do their own research and not just take for granted what people say in terms of their concerns here. There's extensive evidence, and I've given some of it to Dean to look over at his leisure, and I have right here. There's extensive evidence demonstrating that this measure is going to be safe and is going to be a good thing for Massachusetts.
I'd like to say we're talking about question number 4, limited legalization and regulation of certain natural psychedelic substances, and I have Graham here who's explaining it quite well. I'm impressed. And I want you to listen to him and understand and read this ballot initiative number 4, because it's very important to Massachusetts. I think it's a wave that's happening in this country. I think Oregon passed it in 2020. Is that correct?
Yes.
All right.
In Colorado in 2022.
Okay. So it's sort of something that's on the edge and coming. Hopefully, you want it to pass. Is that?
Yeah, no, I really want it to pass.
Yeah.
So I want to talk a little bit about why I'm here.
Okay.
So I was a grassroots advocate for this prior to joining the campaign.
You were what? I'm sorry?
A grassroots advocate for this
right. Okay.
before joining this campaign because of my own experiences as a patient with obsessive compulsive disorder and also as a caregiver for 2 loved ones with severe suicidality leading to hospitalization.
Oh.
I have a family member who's a psychiatrist. I have friends who are doctors. I'm very, very aware with what the highest level of conventional psychiatric care can offer. One of my loved ones was hospitalized at McLean Hospital in Massachusetts, which is the #2 ranked psychiatric hospital in the whole country. And I'm a patient at MGH, which is the #1 hospital for psychiatry in the country.
It is the #1.
It's #1 this year.
It
and
is.
my own psychiatrist, I use psilocybin to treat my disorder in consultation with my MGH psychiatrist, a specialist at MGH.
Okay.
And my loved one who was hospitalized at McLean, she fortunately did well, receiving the highest level of care. But the medications she was prescribed there, they eventually did not work so well. She used psilocybin, and after using psilocybin, her depression went into remission for the first time in her adult life.
Wow.
Now, this is all anecdotal, but it's
Right.
important to contextualize all the research that's been done, both observational and clinical, showing these things are effective. And while my loved one was fortunate with the highest level of care, there are too many people, even at McLean, who are not getting better. I know somebody who's been there almost a year, is on around 15 medications, and she's having to make a pros and cons list over whether to drink water. And I used to be that bad. I used to be living in this living hell where I couldn't take a walk without worrying about, I can't even go into it, but I was scared of the walls in my house, touching them. I'd have to wash my hands afterward. And every single day I walk out of my house, and I know I'm better because I can enjoy my walk, I can enjoy the beautiful blue sky, and I'm not worried about these silly things I used to be worried about.
And you enjoy being on Chumps Telemedia. You're so articulate in regards to the subject matter, and I'm impressed, and I'm thanking you for coming in and expressing your views and going in a little bit into detail in regards to how's it feel when you're doing psilocybin? What's the feeling like? Can you explain that to me?
So it's different for everybody.
Yeah, I'm sure.
But I
and the
actually
amount you take, et cetera, that type.
Yeah, the amount you take. A lot of people are microdosing, which there's not a lot of research supporting that being effective, but they're taking very small amounts that don't cause them to hallucinate or see anything or perhaps even be impaired at all. But in terms of the higher doses, the doses that people are taking in clinical environments and doses that I've taken, for me, it was sort of like a meditation, you might say. I actually haven't really seen things. I don't really hallucinate, but it sort of slows down my life. It's like hitting pause on the remote. It allows me to reflect on my life from a detached, safe, and comfortable space and chart my new path forward. That has been a consistent experience. And on top of that, and they're still figuring out why this is, it just reduces my OCD symptoms very consistently. And there's clinical research being done. It's preliminary, but there's clinical research being done for psilocybin for OCD, my condition. And one of the researchers doing that research recently presented that the results they're seeing with psilocybin for OCD are superior to any other treatment for OCD. And again,
I think that we're going to see that with the VA too. With them doing that study that you were talking about. I think that, because from what I understand, that this is going on. What about FDA approval? I mean, that's kind of like still not there in regards to the federal issue? Or?
It's not quite there, but as I said earlier, we anticipate FDA approval for psilocybin, the most well-studied substance in our measure, within around 2 to 3 years. But even once it gets approved, it's going to be probably prohibitively expensive for many people. Insurance doesn't just cover all new treatments. You can see this with ketamine, which has been shown to be effective for reducing suicidal ideation, but still for a lot of people is inaccessible. So psilocybin will probably be very expensive when it first comes out, more expensive than through our measure. And it will also probably only be available to people who qualify in terms of a very narrow number of conditions or indications. So an OCD patient, for example, might not be able to access it in 3 years. But we do anticipate FDA approval for psilocybin within around a 3-year time frame.
I have 30 seconds. Anything you want to say about the subject matter?
Yeah, the reason we have to do this is because the research is not just repeating myself, but the conditions that this is going to help. PTSD, end-of-life anxiety and depression.